While some patients arrive at the hospital with AKI, many develop it during their stay, often preventable with timely intervention. How to reduce the risk of developing AKI, acute kidney injury, and how to manage it when it occurs is the topic of our video today. This is a clinically focused guide, so we will skip the deep dive into pathophysiology or staging and get straight to the practical steps. Before we continue, if you would like to receive a summary of this video and access the previous video summaries, kindly subscribe to my Substack page. The link is provided below. Let's get started. 4 important practical steps to reduce the risk of acute kidney injury in hospitalized patients: adequate hydration, avoiding hypotension, limiting the use of nephrotoxins, and detecting and treating urine retention early. Let's break down this a bit. For most, adequate oral intake provides adequate hydration. Use IV fluids only when necessary, like in cases of volume depletion or prolonged NPO status. Patients with vomiting, diarrhea, fever, or decreased oral intake for any reason have a degree of volume depletion, and we must optimize their volume status with IV fluids before introducing any nephrotoxic medications, even if their kidney function looks normal. Also, watch out for patients on diuretics. They are at higher risk of dehydration and electrolyte imbalances due to overdiuresis. I always advise my patients to stop taking diuretics if they develop vomiting, diarrhea, fever, or significantly reduced oral intake. Patients with rhabdomyolysis and hemolysis may develop pigment-induced nephropathy, particularly in rhabdomyolysis when the CK is above 5,000. Aggressive IV fluid hydration should be provided to prevent these complications. Patients at high risk of contrast-induced nephropathy, such as those with pre-existing renal impairment, should receive IV fluid hydration with isotonic solutions 1 mg per kg per hour, starting 6 to 12 hours before and continuing for 12 to 24 hours after the procedure or receiving the contrast. This is important. The kidneys are susceptible to low blood pressure, and even brief episodes of hypotension can cause AKI. We must act quickly to stabilize blood pressure and address hemodynamic instability. Palpating the lower abdomen to check for bladder distension should be part of our routine daily exam, especially in elderly males with dementia or encephalopathy. If the patient has an indwelling catheter, urinary catheter, ensure it's patent and draining properly. How about nephrotoxic medications? Several medications may cause nephrotoxicity: NSAIDs, IV vancomycin, aminoglycosides, amphotericin B, acyclovir, methotrexate, cyclosporin, tacrolimus, and IVIG are just some of these medications. Among NSAIDs, ketorolac is the most nephrotoxic and should not be used for more than 5 days. IV vancomycin and aminoglycosides levels should be closely monitored, and I typically have our pharmacy handle that. We must switch to less nephrotoxic antibiotics as soon as we can. IV acyclovir can cause crystal-induced nephropathy, particularly at higher doses. Ensure patients are well hydrated before starting therapy and continue IV fluid during treatment unless contraindicated. So where are ACE and ARBs from this? Angiotensin converting enzymes and angiotensin receptor blockers. These medications are not inherently nephrotoxic. In fact, they are commonly used in patients with chronic kidney disease for their protective effects. However, their use can be associated with acute kidney injury in certain situations, particularly in patients with volume depletions or concurrent use of other nephrotoxic agents. So in general, for medication, always opt for a less nephrotoxic alternatives when an equally effective medication is available. Kidney function and urine output should be closely monitored whenever nephrotoxic medications are administered. In patients with CKD, chronic kidney disease, it's important to avoid nephrotoxins whenever possible. NSAIDs should be avoided entirely, and contrast agents should only be used if necessary. Additionally, ensure all medications are dosed appropriately for renal impairment. Let's talk about AKI management, but first let's quickly review the formal definition of AKI. AKI is defined as an abrupt decline in kidney function reflected by an abrupt decline in the GFR. Now, since the direct GFR measurement is not practical, AKI is diagnosed using creatinine accumulation or decreased urine output using the following criteria: increase in serum creatinine by equal or more than 0.3 mg per deciliter within 48 hours, increase in serum creatinine to equal or more than 1.5 times baseline within 7 days, or urine output equal or less than 0.5 ml per kg per hour for 6 hours. I have 3 comments on this definition. First, trend over times matter. AKI is diagnosed based on serial changes, not a single isolated value. Always compare current kidney function to previous results. If prior values are unavailable and the patient presents with abnormal kidney function, assume it's AKI until proven otherwise. Second comment, BUN is not included in this definition. Serum creatinine is the preferred marker as it more accurately reflects GFR. BUN levels can be influenced by protein intake, catabolism, GI bleeding, or liver dysfunction, making them less specific for AKI. And the third comment, that there is no creatinine cutoff in the definition. That means a normal BUN and creatinine does not necessarily mean normal kidney function, while an abnormal BUN and creatinine may indicate chronic kidney disease rather than acute kidney injury. Now my patient developed acute kidney injury. Once that happened, I reflexively do these 5 things. First, discontinue any potential nephrotoxins and offending agents right away. Second, correct and avoid any hypotension. Third, ask the pharmacy to renally adjust all medications. Fourth, switch to renally safe alternatives if possible. For example, switch from low molecular weight heparin to unfractionated heparin for DVT prophylaxis or anticoagulation. And fifth, I palpate the patient's lower abdomen to check for any bladder distension and place or drain that urine as quickly as possible if detected with urinary catheters. This is particularly important in elderly gentlemen that commonly have underlying BPH. Next is to try figuring out the underlying process behind the acute kidney injury. History and physical exam remain the single most important element in finding out the underlying process of AKI. And let me give you some clues or examples. Patients who are volume depleted, such as those with vomiting, diarrhea, decreased oral intake, and bleeding, are likely to have AKI due to renal hypoperfusion, or what we call prerenal AKI. These patients will have signs of dehydration and sometimes their lactic acid levels are elevated. On the other hand, patients with signs of volume overload, such as those with peripheral edema and ascites, are likely to have what we call prerenal AKI due to decreased effective circulatory volume. And when this happens in patients with congestive heart failure with decreased cardiac output, we call this cardiorenal syndrome, whether type 1 or type 2. The development of AKI in patients with decompensated liver cirrhosis suggests possible hepatorenal syndrome. And it's clear-cut AKI with urine retention suggests obstructive uropathy, or what we call sometimes postrenal AKI. This is mainly seen again in elderly male patients. Can be seen in any patient, but mainly seen in elderly male patients and those with urinary catheters. Acute kidney injury after hypotension suggests acute tubular necrosis. Remember that even transit episodes of hypotension can cause AKI. Medications can cause AKI via different mechanisms. ATN, such as with vancomycin and aminoglycosides. Crystal-induced nephropathy, such as methotrexate, acyclovir, amoxicillin, and sulfamethoxazole. Acute interstitial nephritis, such as with beta-lactam antibiotics, NSAIDs, and PPI. Yes, PPI can cause that. And remember that acute interstitial nephritis comes to my mind when the HNP doesn't point out an obvious cause of AKI. I look if there is any history of recent medication use, infections, autoimmune disease, and common symptoms in these patients include fever, rash, eosinophilia, although again, these are not always present. And the development of AKI in the setting of rhabdomyolysis, especially when CK level above 5,000, suggests possible pigment-induced nephropathy, and this happened again in hemolysis. Remember that, think of rhabdomyolysis in patients with prolonged immobilized state, heat exertions, trauma, certain surgeries, certain drugs. And again, remember that rhabdomyolysis may cause elevated AST and ALT. So if you have those elevated without a primary liver problem, think of rhabdomyolysis. AKI that develops within 48 to 72 hours after contrast exposure may suggest contrast-induced nephropathy. From this, you see history and physical exam can point most of the underlying causes of AKI. Now, even when the cause of AKI seems clear based on the history and physical exam, I always perform urine analysis and renal ultrasound to look for any underlying evidence of obstruction like hydronephrosis. I reserve additional urine tests such as FeNA, fraction excretion of urea, urine creatinine, CAS analysis, and sometimes renal biopsy for cases where the etiology of AKI remains unclear after my initial assessment, although some object this, but when it's very obvious, why to go for all these tests? Now, let's talk about management. The primary objectives of AKI treatment are to halt further damage of the kidney, identify and treat the underlying cause, and manage any electrolyte disturbances and acidosis, and support the kidneys in recovering full function as efficiently as possible. The treatment of obstructive uropathy involves relieving obstruction and managing volume and electrolytes. Urine catheterization relieves the obstruction in most cases. I always consult urology with these patients. If the obstruction is due to BPH, alpha blockers such as tamsulosin must be initiated. Volume management is crucial in these patients given potential post-obstructive diuresis. There is no set rule for fluid replacement here. Ensuring the patient remains hemodynamically stable is the main goal. Some may opt to track urine output and replace it with fluids. Like a 50 to 75% strategy can be used, which means replacing 50 to 75% of the previous hour's urine output with IV fluid. Post-decompression hematuria may develop with rapid bladder decompression, so we need to watch for that. Now, the treatment of prerenal AKI depends on the cause of decreased renal perfusion. Volume depletion is simply treated with aggressive IV fluid resuscitation with isotonic crystalloid solutions. Don't shy away here from using lactated ringer or plasma-lyte because of the concern of hyperkalemia, because they have very small elements of potassium. Bicarb drip should be used instead if metabolic acidosis is present. I use bicarb drip when bicarb level is less than 22. I highly encourage you to watch my previous video on IV fluid solutions, and I'll provide the link in the description field. Volume overload should be treated with IV loop diuretics. Remember here that patients with AKI require higher doses of loop diuretics. Typically, the starting dose of furosemide in this patient 80 mg once to twice daily and 2 mg once or twice daily for bumetanide. Albumin can be administered in patients with low albumin level. Now, albumin used before diuretics may offer short-term diuretic enhancement, and we typically give it 15 to 20 minutes before the IV loop diuretics is given. For more details on the use of loop diuretics, I refer you to my previous video about using diuretics. Also, I will provide the link in the description field. Now, patients with congestive heart failure and low cardiac output syndrome may require inotropes as well. And if we're going to use inotrope, please consult cardiology in addition to nephrology if we decide to do that. Using albumin along terlipressin or norepinephrine, if that's not available, is the treatment of choice for hepatorenal syndrome. Discontinue any potential offending agents if acute interstitial nephritis is suspected, as this can lead by itself to partial or complete recovery of renal function. If there is no improvement in kidney function within 5 to 7 days after stopping the offending drug, corticosteroids are recommended. Prednisone is commonly used here, starting at 1 mg per kg per day for 1 to 2 weeks, followed by a taper over 4 to 6 weeks. Early initiation of steroids in acute interstitial nephritis is associated with better outcomes and reduced risk of chronic kidney disease. Now, acute tubular necrosis is probably the most common form of AKI in critically ill patients. It frequently results in oliguria, anuria, and the need for renal replacement therapy. Remember that oliguria is defined as less than 0.5 ml per kg per hour over 6 hours, and anuria is defined when the urine output is less than 100 ml per day. Anuric or oliguric AKI always makes me nervous. I consult nephrology right away in these patients, as life-threatening hyperkalemia and acidosis can develop quickly, requiring emergent renal replacement therapy. Also in these patients, do not be deceived by initial normal potassium. As long as they are oliguric or anuric, potassium likely will rise despite hyperkalemia management. The same applies to metabolic acidosis. I will not go into the details of treating hyperkalemia and acidosis, as I dedicated previous videos to both topics, and I'll provide links in the description field. Now, the decision to start renal replacement therapy RRT is usually made by the nephrology team. Critical hyperkalemia and severe metabolic acidosis are the two main reasons for emergent RRT in critically ill patients. Nephrology will also decide whether to start RRT early or late, and which form, in the form of continuous renal replacement therapy CRRT or intermittent hemodialysis. CRRT, continuous renal replacement therapy, is typically chosen in patients with hemodynamic instability who cannot handle the fluid shift used in regular hemodialysis. Remember this, for prompt removal of potassium and acids, traditional hemodialysis is the way to go. CRRT is pretty slow in fixing that. Volume overload is another indication for renal replacement therapy in ATN patients. Before initiating RRT in these patients, it may be worthwhile to give a challenging dose of loop diuretics to assess the patient's response here if the patient is stable enough to receive a large diuretic dose. We typically give 1 mg per kg of IV furosemide or its equivalent. Urine output at 6 hours after challenging dose of 6 ml or less is indicative of poor response and potential need for dialysis. RRT or renal replacement therapy is also indicated for uremic complications such as encephalopathy, pericarditis, and bleeding. Renal replacement therapy is also used for some toxin removals. Now, the treatment of crystal-induced and pigment-induced nephropathy is similar and involves discontinuing the offending agents and providing supportive care with IV fluid resuscitation. In some cases, urine alkalinization may be necessary. Nephrology consultation is essential to optimize management and minimize the need for renal replacement therapy. And I understand that some of you may consult nephrology for every case of AKI, but that's not always necessary. Many cases such as AKI due to volume depletion are straightforward and typically resolved with IV fluid resuscitation. So let's reserve nephrology consults for more complex or severe cases, allowing them to focus on the situations that truly require their expertise. Now, how do we monitor AKI patients? Patients with AKI should have their urine output, electrolytes, and kidney function closely monitored. Now, while urine output is routinely monitored in critically ill patients, it may not be tracked as closely for those on the regular hospital floor. We must relay the importance of tracking urine output to the patient themselves and nurses. And I know we aim to minimize Foley catheter use, but if it is the only way to accurately measure urine output, we should use it. Urine output is important. It offers valuable prognostic information and guides further treatment decisions, as we explained earlier. And remember this very important fact: AKI is a dynamic process with a continuously changing GFR and creatinine clearance, and for that reason, serial labs for kidney functions and electrolytes, including bicarb labeled as CO2 on BMP or CMP, must be obtained. For critically ill patients, particularly those with oliguria or anuria, key labs such as electrolytes and kidney function and acid-base status should be monitored every 6 to 8 hours or up to 12 hours depending on the clinical context. Remember, AKI patients, these patients are at high risk for rapid deterioration, including life-threatening hyperkalemia and metabolic acidosis. As we explained earlier, a single normal potassium level or mildly elevated creatinine on the initial BMP or CMP should not provide false reassurance, as these values can shift abruptly in these unstable patients. Now, for stable patients with adequate urine output, daily labs monitoring is typically sufficient. However, more frequent testing may be warranted if significant electrolyte imbalances, worsening renal function, or other clinical concerns arise. Let's finish by talking about the prognosis. AKI due to volume depletion and obstructive uropathy resolves quickly if prompt intervention is provided. AKI from ATN may take weeks to months to recover depending on the severity of tubular injuries and comorbidities, like diabetes or underlying chronic kidney disease. Some patients may develop residual CKD or progress to end-stage renal disease requiring dialysis. In acute interstitial nephritis, kidney function typically improves within weeks if the offending drugs is stopped and steroids are initiated early. In crystal-induced nephropathy, recovery within days with with early intervention, including hydration, IV fluid hydration, urinary alkalinization, and discontinuing the offending drugs. In pigment-induced AKI, aggressive IV fluids to flush out nephrotoxic pigments, myoglobin or hemoglobin, can prevent permanent damage. However, severe cases may still progress to ATN or chronic kidney disease. In the end, if you found this video useful, kindly give it a like, share it with your colleagues, and subscribe to the channel if you have not done so. To read a written summary of this video, kindly subscribe to my Substack page. The link is provided below. Thanks for watching and see you soon.